Hello and a warm welcome to all you lovely people out there who are with me on the screen and who are listening to me. And I welcome you all on board with me to discuss this topic of recurrent IVF failures. I know IVF is a strenuous thing, and most of us have to go through this to attain the ultimate joy of parenthood. And most of us, when we go through this cycle of IVF, get very strenuous and very exerted. And we all want that our IVF should go success in the first cycle of IVF itself. To be really honest to you, it is not that IVF gets successful only after two or three attempts, or IVF doesn't get successful after the first attempt. The success of IVF depends on a lot of factors, and if you understand those factors, you as a couple would never blame yourself or your doctor or your hospital or the people related or close to you that my IVF failed because of this particular person or this particular doctor or this particular hospital. So here I am to give you insight about what happens when an IVF gets failed. There are many factors which are responsible for it, and above all, the most important factor which is responsible for attaining a pregnancy after an IVF is the implantation. Implantation is the attaining of the embryo to the uterine cavity. We as IVF specialists, we prepare everything within a female when we do her IVF. We prepare the endometrium, we prepare the uterus, we prepare the embryo. Everything is good, and we all hope that the embryo would implant in the first go. But most of the times, it doesn't. So, what exactly happens? What are the factors which are responsible for it? There are many factors. The most important is implantation. The embryo has to have a relationship with the endometrium, what we call as the wall of the uterine cavity, and try to cling on to it. That is the most critical step in the success of an IVF. Now, how do you realize that an IVF is successful or it has failed? So, when we do an embryo transfer for the couple, we tell the female partner to do a serum beta HCG or a blood test for pregnancy or a urine test for pregnancy after 2 weeks of doing the embryo transfer. So, that is the first step when a clinician understands that whether the female has become positive or negative. When your blood test or your urine pregnancy test comes positive after 2 weeks of embryo transfer, that means you have had a successful IVF pregnancy. Now, most of the times, what happens is that after the first beta HCG, we always tell you to monitor your beta HCG again after 48 hours or after 72 hours. The most important thing, what we want to look at this when we tell you to monitor your serum beta HCG, is that we have to see whether the pregnancy is growing inside or not. Because so soon to see the pregnancy on ultrasound is very difficult, and that is why we have to monitor it with the blood markers. Most of the times, every 48 to 72 hours, when we monitor the pregnancy, the serum beta HCG values rise, and we are happy to see that the pregnancy is growing. Now, after 5 weeks of doing the egg pickup, we most of the times tell you to go for an ultrasound if your serum beta HCG is positive. And on the ultrasound, we do not see an intrauterine pregnancy, or we do not see the cardiac activity, what we call as the heartbeat of the embryo. And that is why then we can say that the IVF has failed. So it is different in different couples. In some couples, you have the serum beta HCG positive. The values go on rising very nicely. And after 5 to 6 weeks, when we go ahead with the ultrasound to see the baby and the fetal well being, we don't get any cardiac activity. That is one place where the IVF is failed. There can be many reasons for it. There can be that the embryo was not healthy. There can be that the embryo wanted to come into life, but due to some factors inside the uterus, it could not come. So we have to figure out when you come to us with an IVF failure that what exactly happened. So here I get a question that what are the effects of IVF on a body? IVF involves a lot of medicines, a lot of injections, a lot of oral medicines, a lot of medicines to be given by the vaginal route. But there is nothing to worry on that. These medicines have no harmful effect on the body. These medicines are entirely given to the female partner to support the pregnancy. There is one more question which is being asked to me by Bhavna. Why does IVF fail with good embryos? So I would tell you in my lecture when I proceed ahead that why IVF can fail even with good embryos. As I said, that it is not necessary that even after the embryo is of good quality, the embryo would attain implantation to the uterine cavity. So at times there can be implantation failure, there can be defects in the uterus which are not allowing the embryo to implant, there can be some chromosomal defects which we don't know. So all those have to be found out. Why does IVF fail with good embryos? How long of a wait is recommended between a failed IVF cycle and trying again? So that's a good question. Many people ask us that, ma'am, for how long should we wait? Now our beta HCG is come negative and we want to try for another IVF cycle. As per recommendations, I think you can go ahead immediately in the next cycle too. But I, as a doctor, personally would feel that since IVF involves taking a lot of medicines, a lot of stress on your mind, I would recommend you to take a gap of 1 month, normalize yourself, understand from the doctor what exactly is wrong, what happened in the IVF, why it has failed, and then you can take an informed decision with your doctor. So, what are the common causes of IVF failures? There are 5 to 6 basic causes which are evaluated when once an IVF is failed. So one is the quality of the egg. Quality of the egg is assessed by a lot of markers, a lot of blood tests, what we do in a female. We assess the ovary, we assess the AMH, what we call as the anti-Mullerian hormone. We do the basic parameters of a female, that is FSH, LH, and E2 on day 2 or 3 of the menstrual cycle. And we try to assess as to what is the biological age of the female. If a female has got a low AMH, somewhere less than 1 or between 1 to 1.5, then it is a high alert for us, and we understand that the amount and the quantity of eggs what we would get from this female would be compromised, and we have to work on that. So egg quality is one of the very important factor behind the failure of the IVF. Second thing is the sperm. As the egg is very important for creating the embryo, similarly is the sperm. So we tell a man to go for a semen analysis, and in the semen analysis there are a lot of things which we see. We see the volume of the semen, we see the liquefaction time of the semen, we see the count of the sperm, we see the motility of the sperm, we see the morphology of the sperm, and all these parameters are important and responsible for the success of the IVF because they are responsible for creating a good quality embryo. So if the count is low, then we have to take the andrology opinion and work on the semen count. If the motility is low, the couple stands very less chance of having a conception on its own, and we tell the couple to go straight away for IVF. If the morphology is affected, then we tell the couple to go for ICSI, what we call as the intracytoplasmic sperm injection. Now, what is ICSI? IVF and ICSI are two separate things, but quite interrelated to each other. When the morphology is normal and the motility is normal, we normally recommend the couple to go for IVF. But when there are issues with the morphology and to some extent motility, then we tell the couple that we have to perform ICSI, what we call as the intracytoplasmic sperm injection. So in ICSI, there are very high resolution microscopes which are used and the micromanipulators, which help the embryologist to select the best quality of sperm and put it or inject it inside the good quality oocyte. It requires the assistance of an embryologist for fertilization. That is why it is called as intracytoplasmic sperm injection. And in IVF, the only difference is that we put the oocyte in a petri dish with a lot of good quality sperms all around it for it to fertilize on it. So ICSI is basically a treatment of a male factor infertility where people have got issues with morphology and motility. So going ahead, after egg and after sperm, which is responsible for the quality of the embryo, and if the quality of the embryo is affected, definitely there would be affected implantation in the uterine cavity, and that would lead to the success or failure of IVF. The another important factor, what we assess in a couple after the couple has got one unsuccessful IVF, is the chromosomal abnormalities. So we want to rule out whether there was any kind of chromosomal abnormality in either of the couple. And then we tell the couple to go for a detailed chromosomal analysis. If the chromosomal of the couple is found problematic in any of the partner, we tell the partner to go for a donor sperm or a donor egg in whosoever the problem was detected. But if there is no chromosomal abnormality, then we would tell the couple to go ahead for something what we call as a blastocyst transfer to increase the chances of having a successful IVF in the next cycle. Now, what is cyst? Blastocyst is an advanced stage embryo. It is an embryo of day 5, which is created in the lab, and it has got access of implantation, a higher success of take-home pregnancy, and to some extent, it also bypasses the chromosomal abnormalities in a couple. Embryos which are little bit chromosomally abnormal would not go up till the stage of the blastocyst and would get arrested on day 3 or day 4 or maybe on day 2 also. So when we go ahead for a blastocyst transfer, we prefer doing that in people who have got IVF failures and especially in women with advanced age infertility. Because advanced age women have anyways got oocytes which are aging, and so you are reluctant to understand there would be some kind of a genetic abnormality in it. So electively we tell women above 40s to go ahead for a blastocyst transfer, or women who have got 2 or 3 IVF failures to go for a blastocyst transfer. So there is a question from Pooja, and she's asking me, can IVF be successful with low AMH? So IVF can be successful with low AMH. Obviously, with very low AMH, again, the chances of having a genetic abnormality in the embryo is quite possible. So that has to be ruled out. But apart from low AMH, we also look at the age of a woman. We also look at other parameters of the woman when we take the woman ahead for an IVF, and that is the ovarian volume, the baseline FSH of a female, and we also try to find out as to what was the reason when the first IVF went for a failure. How many cycles of IVF can we have? So Priya is asking me, how many cycles of IVF can we have? Priya, there are no such recommendations that you can have only 2 or 3 cycles of IVF in your whole lifetime. But yes, as I said initially, that IVF involves taking a lot of hormones, and it entirely depends on you as a woman and as a couple as to how can you take it forward. If you and your body allows that you can take second or third attempt of IVF easily, you should go ahead with it to get your ultimate bundle of joy. So then I move ahead to the other factors which are also responsible for IVF failures, apart from the egg quality, the sperm issues, the chromosomal defects. So here comes something which is called as the uterus, which is very important for implantation of the baby. So now we have to also evaluate the uterus, that whether the uterus is having any kind of issues inside. So there are some defects in the uterus which are by birth and not evaluated, and there are some defects which can develop in any woman from time to time. So some females come to us, and when we evaluate them, we see that there are certain kind of defects in the uterus, what we call as the septal defects. Some people have got two uterus and two fallopian tubes, which we call as the bicornuate uterus. So these are some kind of congenital anomalies, and this has to be figured out that what kind of a congenital anomaly the female is suffering from. Other defects which a woman can develop over time is the endometrial polyps. Now, what are these endometrial polyps? These endometrial polyps, they are the outgrowths of the inner lining of the uterus. And when they develop inside the uterus, they affect the implantation of the embryo. The solution to this is very simple. It's a surgical solution. We have to simply do a hysteroscopy, what we call as the examination of the uterus. Inside, we introduce a camera and just remove these polyps by a hysteroscopic polypectomy. Once the polyps are removed, the uterine cavity is smooth enough and ready for implantation in the next cycle. So endometrial polyp can be one of the major causes of affected implantation in the embryo, and which leads to IVF failures. Another important thing which most of the women have these days are the fibroids. Now, most of the women have fibroids, and it is not necessary that all women with fibroids would not have a successful IVF. Depending on the size of the fibroid, depending on the location of the fibroid which is there inside the uterus, it entirely depends that whether it is necessary to treat them or whether we can leave it as it is. If the fibroids are small, or you can say less than 5 centimeters, and if the fibroid is not intervening inside the cavity of the uterus, you can leave it as it is. You don't have to touch the fibroid. The fibroid will not cause any harm to the embryo if it is in the wall or in the outer part of the uterus. But yes, indeed, if the fibroid is there inside, and if it's a big fibroid, it has to be managed through an endoscopy. So again, the removal of the fibroid can be done through endoscopy. If it's a smaller fibroid and intervening inside the uterine cavity, you can remove it by means of hysteroscopy. And if it's a bigger fibroid and involves removal of a bigger chunk of uterine cavity, then you have to treat it laparoscopically as well. I still remember there was one of my patient, and she had a multiple fibroid uterus. Multiple means multiple, 15 to 20 fibroids. But they were all less than 5 centimeters. But since she had multiple fibroids, we started removing as much as we could to normalize her uterus and to normalize her uterine cavity. We almost could remove 10 to 12 fibroids, and there were a lot of suturing and a lot of um, reunion of the uterus which was done. That lady had gone for an IVF after 3 months of getting a fibroid removal, and she got successful in her first attempt of IVF. She's blessed with a baby girl. So solutions are there. It's only that you have to understand as to what is the problem, and we will manage it for you. Another most important thing which is responsible for IVF failures is the intrauterine adhesions. Now, what are intrauterine adhesions? This is very important for you to understand. Intrauterine adhesions, or in your language, what we call as a web, which is created inside the uterus. Now, this web can be created due to multiple reasons. There are females who are suffering from tuberculosis, can have this adhesion inside the uterus. There are females who have had multiple DNCs in their lifetime due to any reasons. Maybe they never wanted a baby at that time, and now they are not getting a baby when they want it. So there are women who undergo multiple DNCs. that can create intrauterine adhesions. Intrauterine adhesions can also be caused when certain surgeries are performed on the uterus, and when the uterus tries to heal, in turn, there are fibrosis and there are adhesions inside. So, these intrauterine adhesions can affect your lining, can affect the blood flows inside the uterus, and indirectly, they can also affect the implantation of the embryo. And so, you again land up into an IVF failure. So, if you have intrauterine adhesions, I would like to tell you that again, these intrauterine adhesions can be removed by hysteroscopy. Obviously, there are grading of adhesions which are there. We have adhesions from grade 1 to grade 4. Grade 1 and grade 2 adhesions can easily be managed by a hysteroscopy, but grade 3 and grade 4 adhesions are difficult to manage. We can try a hysteroscopy in that, but we never know whether the implantation or the endometrial receptivity would be affected or not. So somebody is asking me, अगर किसी को tuberculosis है तो IVF success होगा? So that's a very important and a very relevant question. I was just supposed to come to it that some people who have got medical disorders also have got IVF failures, and one of the reasons and one of the medical disorder is tuberculosis. So how does tuberculosis affect a woman? Tuberculosis, maybe it is at any place, be it lymph nodes or be it lungs. Obviously, if it's an abdominal tuberculosis or a tuberculosis in and around the reproductive system, it affects the reproductive system big time. The most important thing which a tuberculosis does to a woman is blocking the fallopian tubes. Most of the times, with such females, when the fallopian tubes are blocked, it is not that we can't open the fallopian tubes. A hysteroscopic cannulation of the fallopian tubes can be tried, and the fallopian tubes can be made to open. But if the adhesions are very strong, we will not intervene much with the fallopian tubes, because that can actually cause a damage to your fallopian tube and a bleeding in and around the tube. So in such case, it is recommended to straight away go for IVF. If the tuberculosis has affected the uterine cavity or the reproductive system, we give you a course of anti-tubercular treatment and then probably take you for IVF after 6 or 9 months of your treatment. So the next important thing which is responsible for the success of an IVF, after we discussed the egg, we discussed the sperm, we discussed the chromosomal abnormalities, we discussed the defects in the uterus, we discussed the defects which are developed over a period of life, like polyp and fibroids. So there are some medical disorders which are also responsible for the success of IVF. So the most important medical disorder, as I told you, is tuberculosis, which is very prevalent in our country, and that causes the tubal defects, can also affect the receptivity of the endometrium. But that does not mean that you don't have to go for IVF. You have to try. Maybe you are successful in your second or third attempt of IVF. The second most important medical disorder, which is very prevalent these days, is the endometriosis. Now, what is endometriosis? Many women are affected with endometriosis. So, endometriosis is a disease where the woman has got the endometrial glands, which in any woman are present inside the uterine cavity, and they bleed every month in the form of a menstrual cycle. But in females who have got endometriosis, these glands are present elsewhere in and around the reproductive system. And these glands also bleed like other menstrual glands every month. But mind you, these glands don't have any place to let the blood out, because when the menstrual glands are bleeding inside the uterine cavity, we have a passage through the vagina from where the blood can come out. But when these endometrial glands are present outside in the ovary or in the fallopian tube or behind the uterus, these endometrial glands are bleeding every month, and this blood is getting collected inside the abdomen. So, in that case, this blood does not have the capacity and the way to come out. Now, what does the body do? The body doesn't understand how to heal it. For it, there is a blood which is there inside. The body has its own healing mechanisms. There is inflammation, there is pain, and till the time the body understands that we have to heal these endometriotic deposits, there is a lot of necrosis, lot of fibrosis inside, which happens in and around the reproductive system. Indirectly, what happens? These deposits, when they start healing or when they start bleeding every month, they spoil the anatomical relationship between the uterus and the tubes. They spoil the anatomical relationship between the tubes and the ovary, and which is very important for a woman to attain a normal pregnancy. That is for sure that if a woman is having grade 3 or grade 4 endometriosis, it is very difficult for a woman to have a natural pregnancy too soon. So then such females have to go for IVF. But endometriosis is one disease which also affects your egg numbers. It also affects your egg quality if at all it is present in the ovary. So most of the females would be having ovarian endometriosis, and the biggest problem with it is that you will have a AMH which would be keeping on falling down and down and down, because endometriosis is like a parasite which is trying to eat the normal tissue of your reproductive system. Again, if the endometriosis is there, it also affects the receptivity of the uterus towards the embryo. So, indirectly, if you are a woman with pelvic endometriosis or ovarian endometriosis, you have a difficult time when you go for IVF. Necessary that your IVF will not go successful in the first go, but you might have to go for multiple attempts before you have a baby in hand. Similar to endometriosis, there is another medical disorder which is also responsible for having or giving you a tough time when you go ahead with IVF. So that is adenomyosis. So similar to endometriosis, adenomyosis is the collection of this blood inside the muscle of the uterus. So when these endometrial glands which bleed are present inside the muscle of the uterus, inside the body of the uterus, the blood keeps on getting collected there. The uterus keeps on increasing in size and it becomes boggy. And indirectly, it affects the receptivity and your IVF success. Another important factor which most of the girls have these days is the polycystic ovaries. So many a times a couple come to us and the female says, "Ma'am, I'm not able to conceive because I have polycystic ovaries." So here I am to tell you one thing. It is not necessary that if you have polycystic ovaries, you definitely have to go for IVF. I do understand that polycystic ovaries causes ovulatory disorders. You might not ovulate every month, but polycystic ovary is a lifestyle disorder. And 50 to 60% of the females can ovulate regularly and can conceive spontaneously if you do little bit of lifestyle changes. Out of that 40% which are not able to conceive and have polycystic ovaries, they might require IVF. Again, a polycystic ovary female has got very less chances of not having a natural conception. IVF is the last resort, and I would tell all females with polycystic ovaries to give it a natural try if they are less than 35 years of age. So then, another important etiology which is responsible for IVF failure, after discussing the medical disorders of tuberculosis, endometriosis, adenomyosis, and polycystic ovaries, we have something what is called as the tubes. So when we go for IVF, it is not necessary that our tubes should be blocked and that is the only reason we are going for IVF. But there are certain complications which happen with the tube and we have to think on the lines of IVF. Now what happens with the tubes? Most of the times, as I said earlier in my lecture, that tubes might get blocked because of tuberculosis. And the only way out to evaluate these tubes is the hysteroscopy. We try to open the tubes by hysteroscopic cannulation, but if we can't and the adhesions are quite adherent, we have to go for IVF. The second most important finding which we have with the tubes is the hydrosalpinx. Now, what is the hydrosalpinx? A hydrosalpinx is a collection of a toxic fluid inside the tube. Now, this collection can be due to multiple reasons. It can be due to an infection which a female has suffered during her lifetime and has gone unattended. It can be due to tuberculosis. Tuberculosis can cause collection of toxic material in the fluid. It can also be due to endometriosis. Endometriosis, the most common complication which happens in the tube is a hydrosalpinx or a hematosalpinx. A hematosalpinx is the collection of blood inside the fallopian tubes. So when you have a collection of fluid or blood inside the fallopian tubes, this is a very important cause of affecting IVF. This fluid, through the reverse mechanism, can come and affect the implantation of the embryo inside the uterine cavity. And this has to be managed if we have come to know that there is something like this inside us. So what are the different managements which can be done for a hematosalpinx or a hydrosalpinx? If it's possible, we could drain out the hydrosalpinx and we could, just remove the fluid out of the tube. But most of the times, if the collection is not easily accessible and we have a lot of blood supply in and around the tubes, we have to cut the connection of this tube from the uterus, what we call as the tubal clipping. So when we do a tubal clipping, which is done by means of a laparoscopy, the connection of the tube, which is having hydrosalpinx, gets disconnected from the uterine cavity, and then this toxic material can't come and implant in the uterine cavity, so it would not indirectly affect the implantation of the embryo. So there are some tubal etiologies which I just mentioned, and these have to be evaluated and found out if these were not the reasons of having an IVF failure. After that, I go on the infectious etiologies, what we call as the infection in the reproductive system. Now, all of us have regular intercourse, all of us use public toilets, and all of us, or most of us, don't maintain a good hygiene. So, all these things can actually cause infections in the reproductive system. Most of the times they are subclinical and we don't even come to know as to there is any kind of infection in the reproductive system. But what harm does these infections cause? We don't know. And in some point of our lifetime, when we have decided to go for IVF, it is at that time that we come to know that, oh, the lining of my uterus is not receiving the embryo. There is an infection. Your doctor might tell you that you are suffering from chronic endometritis, or you are suffering from what we call as PID, pelvic inflammatory disease, in our medical language. So don't worry. There is a treatment. You have to take a course of antibiotics and you would be sorted out for that. But yes, indeed, it is a very important thing which would make you land up into an IVF failure. So any kind of infections in the reproductive system, be it endometrium, what we call as the endometritis, be it PID, what we call as the pelvic inflammatory disease, that is tubes of the that is infection of the tubes or of the uterus, or infection of the cervix, what we call as the mouth of the uterus. There are many women who have got bad, dirty vaginal discharges. They have got bleeding cervix. There are cervical erosions, which the woman is not even aware of. So you have to find out, you have to visit your gynecologist and understand as to where do you stand. And last but not the least, a very important factor for a IVF failure is the genetic abnormalities. Many a times it is not important that the husband has some genetic abnormality or the female has some genetic abnormality, and that is why the embryo will have any kind of abnormality. No. Most of the times, if both the couples are fine, then also the embryo can land up into having genetic abnormalities. So, in such cases, in such females, we try to do a genetic analysis for the embryo, what we call as the PGD, pre-genetic diagnosis, or PGS, pre-genetic screening. So what do we do in this? We do an IVF, we create the embryos, and we take out a small biopsy from these embryos, and we evaluate that cell in the lab, a genetic lab. That genetic lab tells us that whether the embryo is normal or abnormal. If the embryo is normal, we go ahead with a frozen embryo transfer in the next cycle. But if the embryo is abnormal, we have to discard that embryo and we cannot use it for implantation. So, genetic screening or genetic etiologies are also responsible, which can be sorted out after seeing the embryo in the lab. At times, this can also happen that in a couple who has got repeated IVF failures and we receive embryos and all the embryos are having some kind of genetic abnormalities. In that case, the couple is suggested to go for a donor embryo. Whatever genetic abnormality has come, and if we have to change any gamete, whether a donor sperm or a donor egg, we try to do that to give the couple its ultimate chance of attaining parenthood. Okay, so now I would talk about what are the investigations which we do in couples who come to us with repeated IVF failures. So, as I spoke in my earlier discussion, the first and foremost, if any couple comes to us with IVF failure, we take the couple for an endoscopic procedure, what we call as the evaluation of the uterine cavity from the top, what we call as the laparoscopy, and evaluation of the uterine cavity from inside, what we call as the hysteroscopy. So that is the most important diagnostic tool for us, for as IVF specialists, to understand as to what went wrong, why the embryo did not implant. Again, as I also mentioned earlier, also assess the ovarian function of the woman to find out if egg is not the issue for not having an IVF pregnancy. So there are certain basic blood tests which are again repeated and analyzed, which tell us about the biological clock of the woman or the ovarian function of the woman. And this is knowing the AMH, the baseline FSH, and what we call as the antral follicle count. Now, what are these antral follicles? These antral follicles are the precursors of the oocytes, which is present in every woman and are assessed by the IVF specialists to find out as to what is the reserve of the woman. How many eggs should we get? What would be the quality of those eggs? So this is the assessment of a woman and her ovarian function. We would assess the antral follicle count, we would assess the AMH, we would assess the ovarian volume, we would assess the baseline FSH. Okay, so I think I have to finish my session here because the time is up and we would have a further discussion later on. Thank you so much for hearing me.